Bismillahirrahmanirrahim. Assalamu alaikum dear students. We are here with the second part of our topic, which is anticoagulants. In the last lecture we discussed about heparin, its sources, its mechanism of action, low molecular weight heparin, side effects of heparin, and the clinical indications of heparin. And in this lecture we'll be discussing all about warfarin. So the learning objectives of this lecture would be that you should be able to compare and contrast heparin and warfarin on the basis of mechanism of action, monitoring, pharmacokinetics, adverse effects, drug interactions, and treatment of its toxicity. So students, take out your notebooks right now and make a table, and one side of the column please label it heparin and on the other side label it as warfarin, and as you will go along the lecture, keep on noting down the points which are different of heparin from the warfarin. As you have already taken the lecture on heparin, so in this lecture I will be explaining you everything about warfarin, but I will be comparing and contrasting warfarin with heparin. So take out your notebooks and start writing it. So number one difference is warfarin is an oral anticoagulant, whereas when we studied heparin, it was parenteral, so it was given by subcutaneous route. Okay? Whereas the common anticoagulants are warfarin and dicumarol, and they have the ability to antagonize the cofactor functions of vitamin K. The only therapeutic relevant common anticoagulant is warfarin. Initially, the history of anticoagulant oral ones are warfarin was used as a rodenticide to kill the rats. Okay? But what happened? It was seen that when the rats were killed, they had excessive bleeding. So this is how they discovered about the mechanism of action of warfarin and used it as an anticoagulant in vivo and then in other human studies. And now it's widely used as an anticoagulant. Okay? The first difference is the route of administration of heparin from warfarin. The second difference is it's a coumarin derivative, whereas heparin was a glycose aminoglycan. And the third difference you can appreciate is that it is antagonizing the factor functions of vitamin K, whereas heparin was binding to antithrombin 3 and inhibiting clotting factors 2 and 10. So let's see what is warfarin acting. So warfarin is an oral coumarin anticoagulant. It is available as a racemic mixture of R and S warfarin, and the S enantiomer is 3 to 5 times more potent. Okay? It has more anticoagulation property as compared to R, and this can be asked in your MCQ. R and S में से which one is more potent? So if you can remember, S for Superman and S1 is more potent as compared to the R1. ठीक है बेटा? So how does it act? It acts by antagonizing the effect of vitamin K. And what is the function of vitamin K? It is basically causing the coagulation factors 2, 7, 9, 10. Okay? So what happens? Warfarin inhibits the hepatic synthesis of vitamin K dependent clotting factors. Those factors are 2, 7, 9, 10, and also the protein C and protein S, whereas heparin was affecting only factor 2 and factor 10. And similarly, if we add on low molecular weight, heparin was acting only on the factor 10. So we are comparing and contrasting sometimes at heparin and warfarin as well as low molecular weight heparin. So students, in this picture you can easily appreciate the mechanism of action of warfarin. That's basically vitamin K cycle, and the oxidized form of vitamin K is converted into reduced form with the help of vitamin K reductase. And vitamin K reductase, this warfarin inhibits this enzyme, and warfarin exists in two racemic mixtures as I already told you, R and S. And this is very important, as you have already studied in pharmacogenetics, that in each individual the response of the drug is different because of their genetic makeup, because of their metabolizing enzymes. Similarly, there is cytochrome 2C9 which metabolizes warfarin, but it is metabolizing S form of warfarin, whereas cytochrome 1A1, 1A2 and 3A4 are metabolizing the R racemic mixture. If in any individual there is the deficiency of cytochrome enzyme 2C9 or 1A2 or 1A3, then what happens? There is going to be decreased metabolism of warfarin and there's going to be increased toxicity of warfarin in that individual. So it's very important कि जहाँ जहाँ आपको जिस drug के metabolizing enzyme का जिक्र हो वो you have to memorize it. ठीक है, तो मेन सिस्टम है दैट इज साइटोक्रोम P450, उसके अंदर डिफरेंट सब एंजाइम्स होते हैं. ठीक है, एंजाइम सिस्टम्स होते हैं फॉर मेटाबलाइजिंग दीज ड्रग्स. सो ये दिस इज आस्क्ड इन योर MCQ. ठीक है, सो लेट्स सी इन द नेक्स्ट स्लाइड a clear view of the mechanism of action of warfarin. So in this picture you can appreciate this is vitamin K reduced form and it is converting it into vitamin K epoxide, and with the help of NADPH it gets converted into NADP, and these is necessary for the polypeptide precursors of clotting factors 2, 7, 9, 10. They are inactive. ठीक है, vitamin K is necessary for their activation. So active clotting factors 2, 7, 9, 10 are activated when there is addition of the gamma carboxyl glutamyl residues. ठीक है, and this is done when there is conversion of vitamin K into its vitamin K epoxide. ठीक है, and this step is basically blocked by warfarin. That is why there is inactivation of clotting factors. ठीक है, because clotting factors are not getting activated because this step is inhibited by warfarin, so there is anticoagulant effect of warfarin. बच्चों this is a very important mechanism of action of warfarin. एग्जाम में अक्सर ये क्वेश्चन आता है कि what is the mechanism of action of warfarin and what is the antidote for warfarin. So here you can remember the antidote for warfarin is vitamin K, whereas for heparin the antidote was protamine sulfate, and protamine sulfate and heparin were antagonizing each other's effect by which type of antagonism? Chemical antagonism. ठीक है, so another difference of heparin from warfarin is it says treatment of toxicity. Warfarin, vitamin K, heparin, protamine sulfate. Heparin inhibiting factor 2 and factor 10, warfarin inhibiting factor 2, 7, 9, 10, protein C and protein S as well. I hope all of you are clear. Let's move on. So this is the same thing which I just told you, it's in the written form. So the anticoagulant effect of warfarin is observed after 8 to 12 hours after its administration, and its peak effects may be delayed up to 3 days, 3 to 4 days. ठीक है? So if there is an urgent need for anticoagulant effect, so we are not going to give warfarin. Firstly, its route is oral, so in emergency it is not preferred, and its effect is not reached to peak until 3 days. ठीक है, so you will always prefer for heparin which is given subcutaneously. And this is once again the same thing. The effect of warfarin can be antagonized by administration of vitamin K. However, the reversal can take about 24 hours. Why? Because the time necessary for degradation of already synthesized clotting factors. ठीक है? So adverse effects of warfarin. Bleeding disorders. The same common adverse effect with heparin and warfarin, a bleeding disorder, they cause hemorrhage. ठीक है, so in this case you have to monitor international normalized ratio which is called INR. I hope you are familiar with this terminology from your previous background, as well as from prothrombin time. Whereas in case of heparin you were monitoring APTT. ठीक है, so another difference, this is treated by withdrawal of the drug. अगर toxicity हो जाए, there is excessive bleeding, then what you can do, you can withdraw the drug and you can administer oral vitamin K. ठीक है, और अगर उससे भी फर्क नहीं पड़ा और severe bleeding है, then you can give intravenous vitamin K. Then other adverse effects are purple toe syndrome. In whole pharmacology, no drug other than warfarin is going to cause purple toe syndrome. First of all, it's very unique. आप सोचते हैं कि purple toe, वाह, what क्या चीज़ है? So obviously, it's very painful condition. What is happening? There is discoloration of the toes, and it's painful, and happens within first few weeks of starting warfarin. Typically seen in elderly patients and underlying arteriosclerosis. ठीक है, erythematous plaque बनते हैं in the blood vessel, will lead to the release of cholesterol clumps, which gets embolized to hands and feet and leading to obstruction of small arteries. When there is not enough blood supply to the small arteries, जो peripheries में आपके blood vessels हैं, उसके अंदर ये thrombosis हो जाती है, जिसकी वजह से there is reduced blood supply and leads to purple toe syndrome. ठीक है, so there is a picture of purple toe syndrome. It's a classical adverse effect of warfarin in the first few weeks of therapy and seen in elderly patients. Osteoporosis. Warfarin weakens the bones because vitamin K is involved with protein osteocalcin, which is important for bone remineralization. So another adverse effect of warfarin is it causes osteoporosis. Warfarin necrosis. This is another adverse effect of warfarin, in which what happens, it is occurring between the first few days, 2 to 5 days of warfarin therapy, and there is necrosis of the skin where in the high fat content areas like breast, thighs, buttocks, hips and abdomen. ठीक है, and it occurs in every 1 in 10,000 patients which are prescribed with warfarin. And what is the reason for that necrosis? This is the picture showing the necrosis. And warfarin is causing inhibition of protein C, which is a natural anticoagulant. So when it is inhibited, there is coagulation imbalance, which leads to paradoxical activation of coagulation and thrombosis and skin necrosis. तो इनिशियली देखो, आप वैसे तो एंटीकोएगुलेंट दे रहे हो, ठीक है, इसने कोएगुलेशन को स्टॉप करना है ताकि ब्लड जो है फ्लूइडिटी में रहे, लेकिन जब फ्यू डेज, जो फर्स्ट फ्यू डेज हैं, उसमें जो नेचुरल आपके एंटीकोएगुलेंट है जैसे प्रोटीन सी है, ठीक है, उसकी जब इनहिबिशन होगी तो उसको कॉम्पनसेट करने के लिए देयर वुड बी एक्टिवेशन, पैराडॉक्सिकल एक्टिवेशन ऑफ कोएगुलेशन विच लीड्स टू थ्रोम्बोसिस. और ये जो नेक्रोसिस हुई है, दैट इज बिकॉज ऑफ द एक्सेसिव थ्रोम्बोसिस. ठीक है, so it is because of the deficiency, or sorry, inhibition of protein C. So at this point, warfarin is inhibiting factor 2, 7, 9, 10 protein C, protein S, and heparin was inhibiting factor 2 and 10, and low molecular weight heparin was affecting only the factor 10. So adverse effects of warfarin, there is nasal hypoplasia, as you can see in this picture. There's a girl with a severely decreased in the size of the nasal septum, and this is basically because if the warfarin is taken during pregnancy, so it has got a teratogenic effect. So teratogenic effects means that the drug is not safe in pregnancy. It is going to cross the placental barrier and it is going to cause fetal anomalies in the newborn. So remember students, if there is a scenario, as I already told you in the previous lecture, that is a woman who is pregnant and has DVT and we need to give her an anticoagulant. So you will prefer heparin because it cannot cross the membranes because of its large size and its negative charge, right? So you will prefer heparin and not warfarin because warfarin is going to cause nasal hypoplasia and stippled epiphysis. ठीक है? So it's contraindicated in pregnancy. Instead, we can give heparin or low molecular weight heparin. There are few parenteral direct thrombin inhibitors, the name which you should know, which are, what are the advantage of direct thrombin inhibitors? That they are going to bind only to thrombin. ठीक है? They are not going to affect the other clotting factors, in which we have drugs like recombinant herodins, like lepridin and desoridin and agrotoban and biliverdin. ठीक? They are licensed for the treatment of patients with HIT. What is HIT? HIT is heparin induced thrombocytopenia. अगर heparin की वजह से platelet count कम हो रहा है, तो we can replace the heparin with these direct thrombin inhibitors because they are not going to affect the platelets and cause thrombocytopenia. So this is its clinical indication of direct thrombin inhibitors. So in previous university question, once a short question was asked about argatoban. So argatoban is basically a direct thrombin inhibitor and it is metabolized in the liver. It is administered by continuous intravenous infusion and its half-life is about 45 minutes. So it's an anticoagulant, but it's a direct thrombin inhibitor and specially indicated in patients who cannot tolerate heparin because of heparin-induced thrombocytopenia. So students, let's have a look over the MCQs. Why can't heparin be administered orally? Is it large? Is it negatively charged? Does it contain too much magnesium or all of the above? ठीक? So you have to answer these questions. There are few MCQs and one other assignment which will be showing you at the end of the slide. What does heparin inhibit? Is it inhibiting the conversion of prothrombin to thrombin, thrombin to prothrombin, fibrinogen to fibrin, or fibrin to fibrinogen? Sometimes A and C are correct or C and A can be correct. So think about it, go through the previous lecture of heparin and answer this question. Third MCQ is heparin okay in pregnancy, which means is it safe in pregnancy? Obviously, you all should know and you should be able to answer this with closed eyes. Heparin's adverse effects include, there are many which I have already told you and some of them which is mentioned in your books. So either all adverse effects or all of the above or only one. So you have to see. देखो पॉइंट ये है कि all of the above दिया हुआ है and there is hemorrhage, वो तो आपको पक्का पता है. You also know it causes hypersensitivity because it is obtained from animal sources. Then you know about heparin-induced thrombocytopenia. So of course this can be not only single best option, but it can involve many answers. So basically in this question, you have to make the options as many as correct, not only one. ठीक है? Which drugs are used in the treatment of heparin toxicity? This I have mentioned again and again. Chemical antagonism होता है heparin के साथ protamine sulfate का, ठीक है? You can well answer it, but I need you to answer it in your notebook and send the images on the WhatsApp group, ठीक है? Low molecular weight heparins include which of the following? This was your question in your previous lecture, so you can well easily answer that as well. No difficulty. What is the mechanism of action of low molecular weight heparin and why is it different than that of heparin? So I have already mentioned you again and again a difference of low molecular weight heparin is with regard to its clotting factor, which is it inhibiting. The ultra-fractionated or standard was inhibiting two factors and this is inhibiting only one factor. So beta solve it. What are the benefits of low molecular weight heparin? So there are many. So there is another option, all of the above. So it is also a very easy question. Then we have which drug is an irreversible direct thrombin inhibitor that is used in place of heparin when HIT is an issue. HIT is heparin-induced thrombocytopenia when we cannot give heparin. So what would we give? So I've already mentioned. So you have to answer it. Then we have a direct reversible thrombin inhibitor to treat thrombosis in HIT. So the previous question and this question, don't get confused. The difference is reversible and irreversible. So go through your books and see which one is a reversible inhibitor and which one is a irreversible inhibitor. So thank you students for being with me, for listening to me and giving your assignments at time. And a question for your assignment for today is differentiate between heparin and warfarin. As I've already told you from the beginning of the lecture, the differences, but you have to write down in your notebooks with the headings. Headings can involve their sources, mechanism of action, adverse effects, drug interactions, treatment of toxicity, monitoring of heparin or warfarin therapy, ठीक है, and which one is safe in pregnancy. So there are about 10 differences which you can write down, and if you have you can write down the differences, then it will be very easy for you to recall this chapter. So best of luck students, and waiting for your assignments on the WhatsApp group. Thank you very much. Allah Hafiz.